Hello from Montreal. My name is Kirsten Johnson, and I'm the incoming president for the Canadian Association of Emergency Physicians and your host for the COVID Weekly Town Hall. So this is our fourth town hall, and I would first of all like to give a shout out to our producer, Jeff Allen in Calgary, and thank him for his dedication to this project. If you're interested in what he is up to, you can visit his website at jeffallenvideo.com. I'd also like to thank the amazing Christina Bova, who is the woman behind the magic, and she's also worked hard on our CAEP COVID Resource Center, and Patrick Mooney, who is a medical student, and he is helping to organize all of the questions that come from you and that drive our content. So again, it's a strong membership that allows CAEP to provide you with the COVID-19 town halls, a robust information center, and all of the advocacy efforts to date. So thanks to all of those who have joined or renewed this year. And it's crucial now more than ever to strengthen the voice of emergency medicine by becoming a CAEP member if you aren't one already. You can join or renew at caep.ca/membership. If you need assistance, you can contact Christina Bova directly, and her information is on the membership page. We're also pleased to now offer a CAEP members-only discussion forum for COVID-19 available through your CAEP membership dashboard. This forum will feature questions and answers about the COVID-related topics that you watch on our town halls. So if you are a member, you will need your membership to access the forum, and if you're not, you'll need to join. If you need assistance accessing the portal, you can visit the COVID-19 town hall page for instructions, and the button is under the video player. This week's town hall will feature hot topics in COVID-19 point-of-care ultrasound, also known as POCUS. Tonight, we have 5 speakers, and each will have about 15 minutes, and then I will ask any questions that come through our chat. So please do submit your questions as we go on the live stream chat, or text them directly to the number on your screen. So, our first speaker, Dr. Chuck Worster, is the current president of the Canadian Point-of-Care Ultrasound Society, a full-time emergency physician and ultrasound director at the Nanaimo Regional General Hospital. He has been teaching introductory and advanced POCUS courses since 2003 and has taught in every province and territory in Canada. Chuck has personally certified hundreds of physicians, I think even in myself, from coast to coast in POCUS, and is a regular speaker and educator at national and international POCUS conferences. He lives on Vancouver Island with his wonderful wife and 2 amazing daughters, and runs and plays the guitar. He can be followed on Twitter at Chuck Worster. Tonight, Chuck will provide an overview on POCUS during the pandemic and PPE considerations. Dr. Joel Turner will be our next speaker, and he will talk on lung POCUS in COVID patients. He's an assistant professor and an attending staff at the Jewish General Hospital in Montreal. He's the fellowship director of emergency ultrasound at McGill and is an instructor and co-author of the EDE2 and EDE3 courses. He has authored chapters in thoracic, ocular, and DVT POCUS, and he is course director of ePOCUS Essentials courses and bootcamp, and an Apple Distinguished Educator. Dr. Dam Kim is a clinical assistant professor and the POCUS Fellowship Director for the Department of Emergency Medicine at the University of British Columbia. He is also a staff emergency physician at Vancouver General Hospital. He is currently the education lead of the CAEP's Emergency Ultrasound Committee. Dr. Kim will talk about resuscitative POCUS in the COVID patient. Dr. Michael Wu will present on research and interpreting social media as evidence. He is an emergency physician and trauma team lead at the Ottawa Hospital and an associate professor with the Department of Emergency Medicine at the University of Ottawa. He is the fellowship director for POCUS-EM and the director of POCUS-EM research. And last but not least, now famous after being on television for 2 days here in Quebec, Dr. Laurie Robichaud is an assistant professor and an attending physician in the emergency department at the Jewish General Hospital and the Surroi Hospital, and she will conclude our session tonight by putting it all together. So without further ado, I will hand it over to Dr. Worster, who is our first presenter.
Thanks, Kirsten. I just have to share my screen here. All right, I hope everybody can hear me and see my screen. If not, please start shouting profusely. What I'm going to talk about briefly is how to, can't see my screen. There we go. How's that? All right, now you can see my slide. Okay, awesome. Technology can be difficult. Okay, what I'm going to talk about is using PPE for POCUS. And just like we want to protect ourselves during the COVID-19 pandemic, I think we should be protecting our ultrasound machines as well. Where do I work? I work at the Nanaimo Regional General Hospital. If Kirsten introduced that, I won't tell you it's 17 degrees, but it's 17 degrees here. It's a pretty amazing place to live. This is our COVID-19 area in the emergency department. It doesn't look like this now. It's full of PPE gear and carts everywhere. But I'm just going to highlight the fact that it has a skylight right in the middle of it. Our emergency department's pretty unique in the fact that natural light flows through our emergency department pretty much in every area of the emergency department, which is something I've never seen before. I'm going to talk about some conflicts. I don't really have a lot of them, but I have to tell you, I don't have any financial ties to industry. I'm not paid by any drug companies, ultrasound companies, or anything like that. I am paid a presidential stipend to be the president of CPOCUS, or the Canadian Point of Care Ultrasound Society, but I put in way more hours than the stipend covers. And the CPOCUS is a not-for-profit, so we have no external funding, no advertisement. The only way we can keep the lights on is our membership dues. So just like you should join CAEP, it's nice if you can pay your membership dues for CPOCUS so we can keep doing what we do. And then my biggest conflict really is I think POCUS is awesome. And that's one of the reasons that I still think we should be doing POCUS in the COVID-19 pandemic, because it's awesome. It can help your patients. And we're going to hear from our good speakers after I've done about how awesome it can be. So we still need POCUS from my point of view and from the rest of our speakers' point of view in the COVID-19 pandemic, but we want to do that safely. And how do we do that safely? Well, we need PPE for our ultrasound machine. And how do you do that? Well, I think that maybe you should consider doing it using the CPOCUS disinfection protocols that we've had published for a couple of weeks. You can find these on our website. Just go to the home page, and there's a link right on the front page, and you can download them, print them, and start using them in your emergency department today if you want. When are you going to be using these things? So basically, you want to be using these things whenever you would consider droplet protection for yourself. So whatever the patient scenario is, whatever the burden is of community transmission in your community, you want to make sure that you're using PPE for your ultrasound machine the same time you would put gown, mask, gloves, eye protection on yourself. Well, that's when you should be using it. And these protocols were made in an interesting fashion. Mike's going to talk a bit about Twitter and evidence, and people are going to talk about communicating and refining things on Twitter. But these protocols were really made almost exclusively through the Twitterverse, through hashing back and forth between experts across the globe and how to get the nitty-gritty of protecting your ultrasound machine accomplished. And the collaboration was spectacular. So, you know, we can't go to conferences anymore. We can do Zoom meetings and that sort of stuff. We can't actually physically meet with anyone because of social distancing. So the collaboration that I experienced and that we experienced making these protocols on Twitter was amazing. And these are just some of the few people, some of the many people that contributed. And I'm sure I missed somebody here. If I missed you, please tweet publicly that I missed you, and I'll retweet it and have a mea culpa. You know, people on here include people like Kylie Baker, who came up with the unique idea of using wet umbrella covers for covering ultrasound machines. Yeltung Chen from Madrid, who translated some of our protocols into Spanish and was famous for scanning himself while he had COVID-19. And people like Max Didham from Portland, who came up with the unique idea of using basins to carry your portable machine in and out of rooms to clean them. So it really is an international collaboration. It's something that we've published from the Canadian Point of Care Ultrasound Society, but this is really an international endeavor in terms of coming up with these cleaning and disinfection protocols. And here's an example of the two. They're in our two official languages, in French and in English. But the amazing part is that they really have become international in the fact that now we have them in Spanish, we have them in simple Chinese characters, and we've now published them in 11 different languages just in the 2 weeks that they've been released. And we have more languages, translations coming in every day. And our board today came up with the unique idea of sending this off to the World Health Organization, to WinFocus and other societies across the globe to see if they want to use them as well. So hopefully we can spread the word and get people using their ultrasound machines safely. Why are these things important, and why are they useful, and why are they practical? Well, I think they're useful and they're something that everyone can use because they're clear. They have a primarily graphical interface, and they have a very stepwise, methodical approach, kind of like what CPOCUS does for most things. in terms of keeping your ultrasound machine protected and for cleaning to make sure you're not using it as a fomite. And I'm going to give all the credit to the graphical nature and the usability of these things to Sharon Oleskovich, who's the main administrator and a graphical design whiz for CPOCUS. And she's the one that took simple worded approaches written on a Word document and made them into the amazing graphics that we have now. So what are the nitty-gritty, what are the components, the nitty-gritty of these protocols? Well, there's only a few of them, really. The easiest thing to do is really just read the protocols, download them, and modify them or use them in your practice. But the essentials is to leave stuff outside the room that you don't need. Stuff that can potentially become a fomite and something else you might have to throw out or clean. And that means printers, peripherals, cords, anything you don't need, don't bring it into the room. And if you're bringing it into the room, try to protect it. And that really should also include probes you're not going to be using if you have a cart-based system. If you have 3 probes, but you're only going to use 1, then ideally you're leaving a couple of them outside the room. And you could do things like Rob Devins has done here, where he's taken a whole drawer of a cart and made it into an ultrasound drawer. And one of the parts to the cart you see on the top of the screen is a place where you can put probes not needed in the room. So you can protect them, they won't fall on the floor, somebody won't put them in their pocket and walk out of the emerge. You should use covers. So you should try to protect your machines as much as possible. If you can, cover the probes, cover the systems. These little pieces of plastic here are foot covers from the operating room and the enamel that we've used to cover our tablets for using some of our handheld devices. And here, Laxman Pradham from Comox on Vancouver Island uses some garbage bags he purchased off of Amazon to cover his dirty ultrasound machine, the one in the respiratory area of his emergency department, the red machine, covers them and protects them with garbage bags. Use single-use gel packs. So don't bring a whole bottle of gel into the room with you because you're going to have to clean the thing or you're just going to have to chuck it out and then you're going to run out of gel. If you don't have single-use gel packs, then start thinking outside the box. Use some Muco or like Jeff Sheaves done in Toronto, take some 10cc syringes, get your ward assistant or somebody to help you fill them up, fill them full of gel, and then bring a couple of them in the room, and Bob's your uncle. You can scan, and then you just throw the syringes out when you're done. And then one of the tenements of these scanning protocol or these disinfection protocols is really 2 wipes are better than 1. So both of the system cleaning protocols for handhelds or for cart-based systems have a clean inside the room and a clean outside the room to make sure you've both cleaned up the cough debris and bugs, and then you've disinfected it again before you're potentially using it again. And then you might also want to consider, and we throw this into the cleaning protocol, is to clean it before using it, because sometimes it's probably not anywhere you work because everybody is great at cleaning machines, but sometimes I feel like I've gone back and picked up a machine and it feels like a pack of monkeys with spraying gel all over it, and it's obviously not been cleaned. So it's probably a good idea to clean it before using it because you're not sure what happened before you got it. And then think outside the box. If you're having trouble sourcing materials and finding things to cover your machines, then think about unique and innovative ways to do it. And this is a wet umbrella bag. I didn't know this existed before, but apparently it's a bag you can put your wet umbrella in outside of fancy hotels so that when you go into your room, you don't get your room all wet from your wet umbrella. I've been to Vancouver a lot. That's where Dan's from. I've never seen one of these things in Vancouver where umbrellas are ubiquitous, but a wet umbrella bag. You can order these online, and I have some, and we've used them to cover some of our probes and our handheld devices. You'd be like Joel and think outside the box and order some really large garbage bags from Amazon, and I did this too, and used them to cover our machines. We're actually now using bin liners. So our housekeeping department has these giant blue plastic bins they put towels in. They have really big clear liners that they put inside, and we're using those now. We order them from stores, and we're using them to cover our cart-based systems. And you'd be like Aisha Mirza from Edmonton, who thought outside the box and ordered some plastic tubing online, cuts it to size, uses it to cover her handheld device, and then uses some elastic bands from Staples to hold everything together. And you can actually go online and look on her Twitter feed, and she has a video of her demonstrating this as well. And then props to Dan, Kim, and the rest of the CAEP Emergency Ultrasound Committee for producing an excellent document about using POCUS safely in the COVID-19 pandemic, including mirroring the infection control steps and the key points that we did with the CPOCUS cleaning protocol. So props to this committee and to CAEP. So what you should do right now is just share these protocols with people across the globe, because we have them in 11 different languages. Download them, print them, modify them if you need to, because not one size fits all. You may have to modify what you do locally and change some of the steps or clean things inside the room or outside the room differently. Source your gear, find out what works, find out what covers your machine, find out what you're not going to run out of, and source things if you think you're going to run out of something expensive like the hospital supplied probe covers. And then the most important thing is to practice. Don't be doing this on the first time you see a really sick COVID-19 patient. Practice just like you do doffing and donning your own PPE. Practice doffing and donning PPE for your ultrasound machine. Just like Chow Fem from Winnipeg is doing here, where she had one of her residents take pictures of her practicing the covering protocol for the cart-based system. And remember, who's awesome? You're awesome. All the people that help make these protocols, help disseminate them, help translate them, but also everybody who's watching this town hall meeting, you're awesome, because you're putting them yourselves out on the front lines. You're hopefully still using POCUS, you're using it safely, and you're making patient care better. And that's my talk. And on to the good stuff with all the other people.
That's great. Thank you so much. We don't have any questions yet, so to those of you out there, please populate our chat, and we'll make sure that the speakers get your questions. And so I'll hand it over to Dr. Joel Turner.
Great. All right. Thank you, Kirsten. I hope the screen is showing. So again, my name is Dr. Turner. I work at the Jewish General Hospital in Montreal. And over the next 15 minutes or so, I want to discuss a few things. Why we should use lung POCUS in your COVID patients, how to scan your patient's lungs, what to look for in the lungs of your possible COVID patient.
Sorry,
and
Joel,
finally,
do you have a presentation? Because we can't see it. I'm not sure.
Oh, okay.
Yeah. Just hit the share screen button.
Sorry. Oh, there you go. My apologies. Now can you see it? There you go. Okay, my apologies. Okay. All right. So the objectives are basically to look at why you should use lung POCUS in your COVID patients, how to scan your patient's lungs and what to look for, and finally putting this all together in how to integrate your POCUS findings in your patient assessment. Now, what's really important before I really get into it is to realize a few things. COVID-19 did not exist 4 months ago, and as a result, we can't really rely on the usual critically appraised trials to provide us with guidance and policies on how to use lung POCUS in COVID patients. So instead, we have to refer to experts in the fields from around the world that have provided us with their experience and expertise in these types of patients. It's also important to realize that the use of POCUS in COVID patients is very varied around the world, and your use of POCUS may also depend on your comfort levels, the type of hospitals you work in, whether it's in a busy urban tertiary care hospital or a small community hospital. And as well, it depends on some of your provincial policies on how to test your patients with possible COVID-19. So why should we use lung POCUS instead of other traditional methods of assessment? Well, first, it's well established that lung POCUS is superior than chest X-ray for any of the traditional pathologies that we're used to scanning, such as pleural effusions, pneumothorax, and pulmonary edema. It's also found to be comparable in sensitivity to the CT scan. So it's extrapolated data that suggests that this is true as well for the COVID patient. It's also recently been published that in the COVID positive symptomatic patient, that the chest X-ray is normal in almost 60%, showing that it is a relatively insensitive diagnostic tool. Using point-of-care ultrasound, there is less risk of contamination, as it's usually done by the same physician who is in the room and is already protected with PPE. And there is no need to involve other individuals, such as X-ray techs and other machines, as well as other nurses. And it's easier to disinfect a single ultrasound machine than it is to disinfect an X-ray or a CT scan. And if need be, the physician who's already scanning the lungs can assess other organ functions as well at the same time. And there should, as Chuck just mentioned, there should be no equipment in the room that you don't really need, specifically equipment that's dangling around your neck or plugged into your ears. So in my opinion, you should keep your stethoscope outside the room. So in terms of performing the exam, which probe should you use? Well, it's pretty simple that you can use any of the probes that you normally would use on your cart-based system, whichever one you're most comfortable in using. There really isn't no right or wrong probe to use. So remember that COVID-19 causes a multifocal patchy pneumonitis with patchy lesions found everywhere in the lungs. So you'll notice in this patient with COVID-19 that there will be lesions throughout the lungs. And oftentimes, as has been shown in some of the Chinese data, is found predominantly in the posterior and inferior lungs. As a result, you should include more lung zones than what we traditionally teach in lung point-of-care ultrasound. So it is sort of predominant recommendation that for COVID-19, your lungs should be scanned in a 12-zone assessment, and that is 6 zones per lung, 2 anterior, 2 lateral, and 2 posterior. Now, it might seem that you can either scan each individual section, or some people recommend what's called a lawnmower technique, and that is to sort of go back and forth in each of the zones in the anterior, lateral, and posterior areas, and saving clips and images as you go along. Now, it might seem a little bit daunting to perform what appears to be a pretty complicated assessment, but with practice, this entire exam can easily be performed in less than 2 minutes, and often less. Now, when you perform your lung point-of-care ultrasound, it is critical to look carefully at the pleural line. Just to review what normal lung looks like is that you have your ribs with your posterior shadows, and just distal to the ribs will be your white echogenic pleural line that is sliding back and forth. Just distal to that will be your lung. And if you can appreciate in this scan, is that also you'll have some vague horizontal reverberation artifacts, which are called A lines, and in this context suggests normal parenchyma underneath. And if you look more closely at the pleura, you'll realize that the pleura in normal lung is very thin, and here we see that the A lines are these natural reverberating horizontal lines in your lung. So what do you see in a patient that has COVID? Well, first, you will see focal patchy B lines that are seen early in the stages of the disease and in mild infection. The chest X-ray will often be normal in these patients. And what's also important to realize is because this is a patchy disease, you'll often see skip lesions with normal lung that you'll see with normal A-line appearance. Here's another example of a patient with COVID, a 57-year-old male, where you see these focal patchy B lines at the area of the pleura sliding all the way distally. Here's another patient that you'll see some skip lesions with normal A-line pattern. And then as the patients are breathing in this 39-year-old woman who is admitted, you'll see these clear focal patchy B lines that are going all the way down to the bottom of the screen. And oftentimes you will see less movement of the B lines, suggestive of this inflammatory process at the pleura, caused by the pleural layers, which often are stuck together a little bit, and therefore there's less movement of the B lines. Now, eventually, you will find findings of bilateral pneumonitis. And this is where you will see these diffuse B lines, which will then begin to coalesce and form what looks like a large area of white right here, which looks like a waterfall, hence the term a waterfall sign. And here's another example of a patient with bilateral pneumonitis where you have this pleura, which instead of being thin and smooth, becomes a lot more ragged, and as we can call it, a lumpy, bumpy pleura. And also, just underneath the pleura in these areas, you'll see this dark area of subpleural consolidation, of a hypoechoic consolidation, which is also very pathognomonic, as seen in these pneumonitis cases. Here's another example of a 74-year-old female who unfortunately passed away, of these coalescing B lines right here, and this area of subpleural consolidation and hypoechoic consolidation that are usually a few centimeters in size. Here's another example where you see a few B lines in this area of subpleural consolidation that with B lines just underneath it. the findings of COVID-19. And then finally, eventually, you'll have frank consolidation, as you'll see right here, of a consolidative process with some air bronchograms suggesting possibly a bacterial superinfection of these patients. So just to remember that these B lines and pleural findings can be distributed in any pattern with skip lesions between these areas of where you'll see normal lung in between these areas of abnormal lung. What's come out of the articles from China, literature from China, is that most pathology is found in the posterior and the inferior aspects of both lungs. And it's also important to realize that these findings are non-specific and can occur with any form of pneumonitis. So while it is a sensitive test, it won't be specific for COVID-19. Now, as I mentioned, it is really important to look at the pleural line. For example, if you see a patient who has shortness of breath or hypoxia, and you see diffuse B lines with no skip lesions of normal lung, you look at this pleura and you'll realize the pleura looks quite thin and quite smooth, and there's no subpleural consolidations. This is unlikely to be COVID-19 and more likely to be pulmonary edema that we are all used to seeing. It's also been revealed that pleural effusions are quite rare in COVID-19. So again, if you have a patient who comes in short of breath or hypoxic, and you see a rather large pleural effusion, this is unlikely to be COVID-19, and you should consider other diagnosis. So trust your POCUS. It will show you findings that your chest X-ray won't. This is just an example that was seen earlier this week at our hospital, a 59-year-old male who came in with some sore throat, fever, and possibly a history of hemoptysis. His point-of-care ultrasound showed normal lung, followed by this area of waterfall sign of coalescing B lines. So concerned about this patient, we went on and did an X-ray, which, to be quite frank, looks quite unremarkable. But again, I was concerned about this patient, so I underwent a CT scan. And as you'll see from the CT scan, the area of consolidation that was seen specifically where I saw on the POCUS was seen very clearly on the CT scan in the lateral aspect of the lung, closer to the base. So trust your POCUS. It will actually find things that you won't expect. So I could show you abnormal images all throughout this talk, but the real question is, what is the utility of POCUS in your assessment? How can you fit this finding into your decision making? So I could break this down into sort of three categories: into your initial assessment and diagnosis, how to quantify the extent of the disease and the progression of the disease, and then finally, how does POCUS help you with your decision and management of your patients with COVID-19? So it's an important caveat, though, is that any imaging, whether it's POCUS, chest X-ray, or CT, does not actually diagnose COVID-19. It can help you increase your likelihood of the disease. It can define the extent of the disease in your patient, and it can suggest an alternate diagnosis where it is appropriate. So just before I show you, I have to realize that to get an idea of how other people around the world have used POCUS in their initial assessment, it's really based on the experience of some of these doctors around the world who have seen and used POCUS extensively and obviously see a lot of patients. There is no one-size-fits-all recipe for everyone, and so it really will depend on your site and how you can fit POCUS into your flow. This is an example of Giovanni Volpicelli, who, as many of you know, is sort of one of the experts of lung ultrasound based out of Italy in Turin. And of course, that's one of the hotspots of COVID-19. He built this sort of assessment protocol where patients who usually just came in and had normal x-rays, he would basically bring them into two simple categories. If your patient presented with a cough or a fever or any shortness of breath, you were immediately placed into an isolation room and you would have a lung point-of-care ultrasound done immediately. If your lung POCUS was completely normal, patients would have a COVID test, they'd be sent home, and they would be self-isolated waiting for a test result. However, if their lung ultrasound was positive and showed abnormalities, they would get further blood work, they'd get a COVID test, and most of these people, he says, were admitted and had some treatment initiated. Now, clearly, this is not a possible recipe for where you work. So just use that as a possibility. For those who've used Butterfly and have looked at the Butterfly network, here's Mike Stone, who works in Portland, Oregon, who has also brought a recipe or a proposed protocol, but again, has not been validated, and is just a suggestion of how you can use point-of-care ultrasound in your initial assessment. Again, they use a patient coming in with symptoms of COVID. They would get the COVID testing, get pulse oximetry, and immediately do a POCUS ultrasound. And based on the findings of POCUS ultrasound and the need for supplemental oxygen or not, he would provide recommendations of either being discharged home or being admitted for further workup. So with all that to put together, you know, if I had to put this together in my experience of what I've seen in our hospital, I could probably categorize the patient that you're going to be seeing in 4 different areas. If you see your patient coming in with shortness of breath, fever, or any other symptoms that you're concerned about COVID, and your point-of-care ultrasound shows an A-line pattern, that means that you've got normal parenchyma throughout both lungs. So COVID is still a possibility, and your options are based on your patient's clinical status. You can either discharge this patient home, and again, based on your provincial policies, you could do a COVID test. You can consider an alternate diagnosis in this patient who is symptomatic but who has a normal lung ultrasound. So could this patient have a COPD exacerbation? Could he have a pulmonary embolism, in which case you should maybe look at the heart and maybe look at the legs for possible signs of DVT. But what's important is that your assessment should avoid the use of asking for a chest x-ray, because your lung ultrasound is already normal. And by avoiding the chest x-ray, you will avoid a contamination risk in these patients who are still possibly infected with COVID-19. Now, if your assessment by POCUS shows some small focal patchy B-lines or some lumpy bumpy pleura or subpleural consolidation, as mentioned, well, your COVID-19 diagnosis is certainly much more likely. And again, based on your symptoms of your patient, hypoxia, oxygen needs, clinical status, again, these patients can be discharged home. You can explain to them that they most likely have COVID-19 based on the ultrasound finding. And again, your testing of COVID is based on your provincial recommendations and policies. But more often than not, these patients might need to be monitored in your emergency department with further testing or potentially admitted to your COVID floor based on your initial COVID POCUS findings. If these patients then have developed this diffuse patchy coalescing B-lines or consolidation, now these patients are going to obviously be much sicker and are more likely to be admitted to your patient's COVID floor with your regular testing. But because these patients may have more extensive disease, there's this question that ICU might need to be discussed or called earlier than usual, as there might be a consideration that ICU admission it might be more likely. Now, in the last category of patient is if you see a patient who is short of breath or hypoxic, and you see diffuse B-lines, a very thin pleura, maybe a pleural effusion, well, you can be comfortable in saying that COVID-19 is actually quite unlikely in these patients. And as a result, you have to manage these patients for the alternate diagnosis, and in this case would likely be pulmonary edema. What about quantifying disease and progression of disease? Well, in traditional pathology, such as pulmonary edema, there are scoring systems that have traditionally been used and can help determine the extent of lung involvement. Now, there is some data out of China that shows that the more the area affected lung is directly correlated with a need of intubation and for a worse prognosis. However, some other experience from Italy shows that there's actually no correlation. And so there really does need to have more data that before we decide specifically about that. There is some research that came out of China that showed that serial lung ultrasounds can actually follow the progression and resolution of the disease. And this can also help in leading to fewer chest x-rays and fewer CT scans. What about management? How does the findings of POCUS help you in deciding how to manage these patients? Well, there's some research and some expert opinion that suggests that the pattern of localization of the B-lines may provide clues of treatment based on the need for improved lung recruitment. Now, this is more of an ICU-based question, but if you're seeing patients who are intubated with diffuse B-lines, that this may indicate a need for increased PEEP. versus another type of pattern where if you see most of your abnormalities and your consolidations and effusions primarily in the posterior lung, this patient may respond well to pronation. And what has been shown is that serial POCUS of these patients can also assess the success or failure of these maneuvers. So in summary, I think it's important to realize that the use of lung ultrasound is essential in the safe management of the COVID-19 patients in this outbreak. It's simple, it's rapid, and it's an effective test to use at the bedside. It can provide a valuable data point in your decision-making assessment and can minimize the contamination risk to your fellow healthcare workers. So just to finalize a couple comments that I want to end up by providing a few Twitter quotes from some of the lung experts in the field who I follow, who have tweeted out their impressions of the importance of lung ultrasound in these patients. We discuss Robert Arnfeld, who is an intensivist in Ontario, who talks about portable chest X-ray requires a lot of cleaning and PPE and is an awful test in this type of patient. CT scan is a great test, but also you need to transport the patient and then you have to clean the scanner. The sweet spot in his opinion is the lung ultrasound. Talk about Peter Weimersheimer, who's in Vermont. He states that, frankly, getting a portable chest X-ray and not doing lung ultrasound exposes additional personnel to COVID and wastes PPE for a less sensitive test. Not having the initiative to learn a relatively basic application is not a valid excuse to negatively affect colleagues and resources. So I think you need to consider your POCUS as your first diagnostic tool to examine your patient after your vital signs, and leave your stethoscope outside the room. But remember, with such a fast-moving target, firm, critically appraised evidence-based guidelines have yet to be established, and the recommendations are really often concerned eminence-based instead. And as Chuck just mentioned, and Michael Woohoo will probably discuss, the use of Twitter and social media from experts in the field to help guide with your management is a critically important tool. And it also helps you keep apprised of some of the published material that comes out very, very rapid succession. And with that, I thank you.
Thank you so much, Joel. So there are some questions for you. Actually, we'll just go back to Chuck there was one question for you, Chuck, that I missed because of the delay. And the question was, do you use POCUS for every person? Do you use the same approach you shared with us earlier for all patients receiving POCUS, or just those that are positive for COVID or a suspected COVID case?
Well, that's sort of the same can you hear me? Hopefully you can hear me. That's sort of the same question you would have for your local infection control people when you're examining patients. So it really depends on what you're doing locally with your PPE personally. Like, I've worked in 2 different places through the pandemic, and the PPE protocols were different. If in doubt, the same thing applies. If in doubt, wear your personal PPE. If in doubt, put the PPE on the ultrasound machine.
Great. Mm. 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 Okay, so then, the next questions are for Joel. So we do need Joel to at least unmute his microphone if it's not. So great images, and it seems that they're all done with curvilinear and linear probes. Any role for phased array ultrasound probe in these patients?
Yeah. Like I mentioned, you can use any of the probes. There are some people that recommend using a linear probe because you see very high frequency at the pleura. Oftentimes, if you're going to be scanning, you're going to be scanning the lungs and the heart, you might want to just bring in your phased array probe and do both. So absolutely, you can do with either one. Any of these probes are appropriate.
Great. And can you comment about a lung ultrasound's inability or ability to see deeper consolidations? Will we miss these if we trust POCUS too much?
There's no question that with all lung ultrasound, it's based on artifacts, and it is based on the ability of these artifacts or the lesions to be connected with the pleura. As soon as there is a distance between pleura and the lesion, you won't be able to see it on lung ultrasound, because as soon as the sound waves hit air, it'll be dispersed. So if you're identifying a single lesion that is deep, you're not going to see it on lung ultrasound. But for all intents and purposes, these lesions are all abutted by on the pleura, and you'll see them very clearly on your lung ultrasound.
Great. And what's the ideal position for the patient if you're looking at the pleura?
So, I mean, that's a great question. The answer will be really based on how sick your patient is and what comfortable position your patient can be. I mean, if your patient is being brought in extremis and they're about to be intubated, you clearly can't have them sit up so that you can scan the posterior aspects. But if you are going to do their anterior lungs, lateral lungs, and if you have some time to sort of put them on their side a little bit, then that's great. Although I think it's really important in those exceptions of extremis, if you can have these patients sit up, a lot of these patients can't lie down anyway, then as you would normally listen to the back of their lungs with a stethoscope, which you shouldn't do, you should just look at the back of their lungs with the ultrasound.
Great. And I'll just ask one more question, and maybe we'll save the next one for the next speaker. Early reports suggested using presence of pleural effusion as a feature to rule out COVID. How have you been interpreting in context of patients that may plausibly have pre-existing effusions? And do you think that advice still applies?
Well, I mean, in terms of pre-existing effusion, it's hard. I mean, I have absolutely seen patients who are coming in short of breath, and they're brought into our rule out COVID section of the emergency department. And when I scan them, they have large pleural effusions and nothing else in terms of focal patchy B lines. And so these patients, for me, are more or less ruled out, and they are going the route of a cardiac cause of their symptoms. So if I'm seeing these patients with moderate to large pleural effusions, I am quite comfortable in stating that this is unlikely to be a COVID infection. But remember, POCUS is one data point. You have to put the whole scenario into consideration. If they have a fever and they have other symptoms concerning for COVID, well, you have to, maybe do other tests such as a CT or other blood work that helps.
Great. Thank you so much, Dr. Turner. I think we'll hand it over to Dan Kim at this point in time, and keep the questions coming. They're great, and I will continue to field them to our different speakers.
Okay, thanks so much for inviting me to speak about resuscitative ultrasound. I'll start sharing my screen here. Can you all see my screen? So before I start, I have to mention I'm on the medical advisory board, declares, sorry, not yet, eh? Oh, interesting. Okay, let's try this again. 1 second. Yeah, is it all good? Okay, perfect. Okay, so like I said, before I start, I have to mention I'm on the medical advisory board of Clarius Mobile Health. I won't be discussing any of their products or devices, so this shouldn't lead to any conflicts of interest. I know Chuck's already spoken about PPE considerations, but I really can't stress the importance of safety enough. I mean, it's not just an issue just for you; it's an important issue also for your team, as well as your clinical department. In fact, the American Heart Association just revised their ACLS guidelines for patients with suspected or confirmed COVID. And honestly, in today's reality, I think you just need to assume your patient has COVID if they're super sick and need resuscitation, regardless of whether or not they have respiratory symptoms or fever. I mean, we've seen plenty of cases of atypical presentations like abdominal pain, generalized weakness, stroke-like symptoms that have ended up being secondary to COVID. Notice here that the very first step in the algorithm is to take the time to don on PPE for yourself, to limit the personnel involved, and to consider whether or not the resuscitation is even appropriate. If you're resuscitating, assume that your ultrasound machine is going to be in an environment where there will be aerosol generating medical procedures. So, like Chuck said, cover your machine and your probes completely. This photo's credit to Michael Wu. But this is obviously much easier with a handheld unit. In fact, handheld units are generally going to be better than cart-based units in these situations because they're much smaller and they're much easier to clean. For example, where I work, all of our sickest patients are going into negative pressure rooms like this one. And you can see there's really not much space. I mean, think about trying to maneuver a cart-based ultrasound unit into a room like this. It's a nightmare once you start populating a room with a sick patient, a nurse or two, an RT, a ventilator, other resuscitation equipment. So really, if you do have access to a handheld, it's going to be much easier to deploy and use your ultrasound. So let's start with the basics. There's really an alphabet soup of different resuscitative ultrasound protocols out there. Don't worry about this. What you want to do is you want to use a resuscitative ultrasound algorithm that you are comfortable with. This is not the time to start changing your practice dramatically. I personally like the RUSH protocol, rapid ultrasound for shock and hypotension. So while the protocol may seem a little bit complicated when you go through all the different views you can look at, the easiest way to break this down is to think about the cardiovascular system consisting of a pump, a tank, and pipes. If your patient's hypotensive, you have to identify where in the circuit the breakdown is occurring. From what we know about COVID, we know that cardiovascular complications are common, including pathology like arrhythmias, myocarditis, acute coronary syndrome, venous thromboembolism, cardiogenic shock, and heart failure. As a result, I think the highest yield aspects of your RUSH exam are going to focus on the lungs, focus on the heart, focus on the lungs specifically to rule out pneumothorax, the IVC, as well as the deep veins of the leg. You know, it's interesting, the American Society of Echocardiography recently just published a statement on point-of-care ultrasound. I think this just came out maybe 4 or 5 days ago. They actually said that the rapid bedside assessment of the heart, chest, and vessels by point-of-care ultrasound has propelled this tool to the front lines of the fight against the COVID-19 pandemic. You know, it's really amazing to think that an organization that calls for some of the most rigorous standards for echo training, they're actually currently endorsing the use of point-of-care scanning. You know, the amazing thing here is that it seems that this pandemic has, to a certain extent, broken down some silos in medicine and has resulted in different specialties working more collaboratively together. So I want to highlight a couple of COVID-specific issues when it comes to pathology. So the first is the issue of cardiac complications. We know that rates of cardiac involvement when it comes to COVID are relatively high. For example, this study by Go looked at 187 patients with COVID, and 28% of them had myocardial injury as defined by a positive troponin. Of these patients, the mortality rate was 60% versus 9% in patients without a troponin elevation. Similarly, she published a paper about 416 patients with COVID, and 20% of them had myocardial injury, again defined as a positive troponin. And again, mortality was much higher in the group with the elevated troponin, 51% versus 5%. Now, the exact mechanism behind myocardial injury isn't known, but people have speculated about various processes that may be involved, like ACE2, cytokine storm, direct viral damage, and hypoxia. So when it comes to thinking about cardiac complications, we obviously want to scan the heart. In the published literature, clinicians have described echopathology like LV dysfunction, wall motion abnormalities. So here we see the apical septal part of the LV really isn't contracting at all. In fact, I saw a case report about a Takotsubo Cardiomyopathy caused by COVID, just published, I think, yesterday. So we see apical ballooning here. And pericardial effusion. So this is on a parasternal view, and we can see here, inferior to the heart, that there's a pericardial effusion. So this is a good time to review some obvious pathology we can identify in ultrasound at the bedside. So I think a good place to start is with gross assessment of LV function. The reality is I'm not really interested in trying to figure out, is the LV ejection fraction, is it 48% or 53%? What I'm really interested in is just an eyeball assessment that tells me if there's a major problem with the left ventricle systolic function or not. So we can assess this relatively easily by looking at 3 main aspects of the left ventricle. So we can look at endocardial excursion, myocardial thickening, and movement of the mitral valve. So endocardial excursion, what it is, it's the movement of the walls of the left ventricle into the chamber. The endocardium should be moving symmetrically towards the center of the left ventricle during systole. Myocardial thickening refers to the increase in the thickness of the myocardium by about 40% in all the LV segments during systole. So the wall should be thickening appropriately. And lastly, movement of the mitral valve focuses on the anterior leaflet of the mitral valve. In a heart with normal LV systolic function, the anterior leaflet should come within at least a centimeter of the septum in early diastole. So, for example, here's hyperdynamic LV. So this LV becomes almost completely obliterated during systole, which isn't normal. In contrast, this is a normal LV. So we can see that the walls appropriately thicken. We can see that the anterior leaflet of the mitral valve hits the septum. This video depicts moderately depressed LV function, sort of moderate to severe. The walls of the LV are moving towards the center of the chamber, but they clearly aren't moving as vigorously as our normal example. And the anterior leaflet of the mitral valve really doesn't approach the septum. And this heart demonstrates severely depressed LV function. The walls of the LV hardly appear to be moving. I mean, they just kind of appear to be quivering. This is also a good time to review echo signs of cardiac tamponade. If you see a large pericardial effusion and your patient is hypotensive, it's a good idea to treat it as cardiac tamponade. However, if you see these signs on echo, it should make you concerned as well. So right ventricular collapse in diastole, that's an echo sign of tamponade. So you can judge this by slowing down your cine loop. And effectively what you're looking for is you're looking for the point at which the mitral valve opens. So we can see that the mitral valve is open there in early diastole when it should be filling, and the right ventricle is collapsed instead of distended. Abnormal right atrial collapse is another echo indication of tamponade. And finally, a plethoric IVC without respiratory variation is concerning for tamponade. So another COVID-specific issue is the high rates of venous thromboembolism seen in these patients. CAEP published a study of 81 ICU patients with COVID, and there was a 25% incidence of venous thromboembolism. And of these patients, 40% of them died. Clock published this paper about their experience in the Netherlands with 184 ICU patients with COVID, and they had a 27% incidence of venous thromboembolism, the majority of which were PEs. So if we're thinking about venous thromboembolism, we're going to focus on scanning the heart as well as the deeper veins. Ultimately, echo signs for PE are poorly sensitive, but they have reasonably high specificity for pulmonary embolism. So you might see a situation like this, like a dilated RV, where the RV is large or larger than the LV. That's clearly abnormal. In peristernal short axis, the LV may appear to look like a D-shaped structure instead of a nice round ventricle due to the pressure overload from the right side of the heart. You might see something like McConnell's sign, which manifests as akinesis of the free wall, of the RV free wall. So the RV free wall doesn't move as well, but there's preserved contractility of the RV apex. And the most specific sign of PE is to actually see clot in transit. So we can see here that there's some clot in the right atrium. Lastly, plethoric IVC without respiratory variation can also be seen in the setting of a submassive PE as another manifestation of right heart strain. However, some clinicians have also reported the development of right heart dysfunction and pulmonary hypertension simply due to COVID, even in the absence of PE. So to really help solidify your diagnosis of PE, it can be helpful to take a quick look at the deep veins of the legs. The idea here is to perform a simplified two-zone compression assessment in the femoral area as well as the popliteal area. So all you may see is an absence of compression of the vein. So here we're in the femoral area, and what we can see is that we know we're compressing adequately because the femoral artery is actually becoming compressed, but the femoral vein won't. That indicates that there's something within the vein stenting it open, meaning it has a DVT. Occasionally, you may see actual thrombus, like this example of a popliteal DVT. So we can see that in the popliteal vein, there's some echogenic thrombus within it. The European Association of Cardiovascular Imaging has published recommendations where they suggest that all echoes, even including consultative echoes, start as a focused scan to assess the LV, the RV, and for pericardial effusion. This is certainly within our scope as emergency physicians using point-of-care ultrasound. But also remember, in the midst of this COVID pandemic, don't forget that we are also going to see patients that have non-COVID pathology. So albeit that level of pathology in terms of the number of patients seems to be a lot less than we've had previously, patients are still going to present with things like a ruptured ectopic or a ruptured aortic aneurysm. The last topic I want to talk about is central venous access. So I noticed this on Twitter about a month ago. So this individual posted a Twitter poll where he said, "A less discussed consequence of COVID-19 in ICU, a resurgence of landmark central lines as ultrasounds are difficult to properly disinfect. Many trainees have never done one without ultrasound. Are you confident in doing landmark technique? Which are you most confident in?" So over 2,100 votes and 30% of the respondents said yes to the subclavian. As if we don't need to be reminded, the evidence for ultrasound-guided central line insertion is overwhelming. This meta-analysis included 26 studies with almost 4,200 central line insertions, and ultrasound guidance resulted in lower failure rates, lower rates of arterial puncture, and lower rates of pneumothorax. In fact, the Agency for Healthcare Research and Quality published this report called Making Healthcare Safer in 2013, and they provide a top 10 list of the healthcare practices that have the most evidence supporting their use to improve patient safety. So this list includes things like pre-op checklists, hand washing, barrier protection, as well as ultrasound-guided central line insertion. So basically, if you believe in science, you should continue using ultrasound guidance for central access, regardless of whether or not we're in a pandemic. You're really not going to look too clever if you cause an iatrogenic pneumothorax in a patient with COVID. As Chuck covered in detail earlier, there are steps involved in terms of cleaning and disinfecting your ultrasound machine properly. And if you want to be really slick, you can inject 10 cc's of saline into your central line to see if the line's been appropriately placed. You should see a rapid atrial swirl on the right side of the heart within 2 seconds of injecting your saline. Additionally, you can take a look at both lungs to ensure that they're sliding to make sure you haven't caused a pneumothorax. So in summary, we talked about the importance of your safety as well as the safety of your team. The first step is to don appropriate PPE for both you and your machine. Use the resuscitative ultrasound protocol you're most familiar with to assess the pump, the tank, and the pipes. The highest yield areas to scan in a patient with known COVID are going to be the heart, the lungs, the IVC, and the deep veins. Be aware that cardiac complications are common in COVID, especially problems like cardiomyopathies, myocarditis, pericarditis, ischemia, and heart failure. Develop some familiarity with the point-of-care ultrasound findings of venous thromboembolism. And lastly, continue to use ultrasound guidance for central venous access, as this is standard of care, even in a pandemic. So it's been a pleasure. Happy to take questions at this point. Feel free to contact me by email or Twitter, and I will hand it back over.
Thank you. That was great. So there was a question on PE, but you answered that in your presentation. A couple questions, and maybe I don't know if it's you or Joel. How likely are we to miss a subtle bacterial pneumonia as an alternative diagnosis if the consolidation is deeper into the lung? And are you prescribing antibiotics for a query atypical bacterial pneumonia, which also can give you bilateral patchy B lines on POCUS versus COVID, or how are you differentiating? So I'm not sure, Dan, if you're comfortable taking those, or if we want to send them Joel's way.
I don't know. What do you think, Joel? You're the guy giving the talk about lung ultrasound.
The question about, it's interesting because anyone coming in nowadays, it depends on where you work. Everyone coming into our hospital with symptoms of respiratory distress or fever or infection, they're COVID. So to say that you're going to miss an atypical pneumonia, is not as likely because the rate of COVID is so high in our hospital, and Lori will discuss that in her talk. To miss a very small lesion that's distal, yeah, like I mentioned in my talk, you're not going to see that on an ultrasound, but I doubt you're going to see that on any other imaging other than a CT scan. But in this time and age where everything is COVID, I think that's where our money is. If you're seeing patchy B lines with a lumpy, bumpy pleura, this is COVID until proven otherwise. There are other blood tests such as procalcitonin and things that I'm not sure what other people use that we use to see if there is a pneumonia as well that we can treat.
Great, thank you. And just a last question, how common is it for you to see a pericardial effusion or a tamponade, and have you seen those in your practice, Dan?
Is the question related specifically to COVID, or?
Yes, related to COVID.
I don't know what the exact incidence is. I mean, I've seen other papers quote that, there's sort of myocard or cardiac involvement or cardiac injury. Other papers have defined it as a positive troponin or abnormal echo findings. And again, they quote rates that are between 15 to 20%. The vast majority of those, though, are simply elevated troponins. So I don't think it's super common to get pericardial effusions, but it seems to be something that happens maybe less than 1 to 2% of the time in terms of what's quoted in the literature. But I think if someone truly does have pericarditis, I think it's and they're short of breath, right? Like all these patients are. If you're not sure, it's certainly worth taking 10 seconds to throw the ultrasound probe on to take a look, because there's really no other way that you're going to make that diagnosis. I mean, we know that, for example, chest X-ray is not going to be a great way to make that diagnosis, and anything else short of a CT isn't actually directly visualizing the pericardium.
Thank you. Excellent presentation so far. And so I'd like to hand it over to Dr. Wu, and he will pick it up in terms of research and social media. Thank you.
Hi, everyone. Thanks so much for having me here. Some really great learning and teaching. Chuck, Joel, Dan, fantastic stuff. And I don't have any slides, actually. So I wanted to keep this relatively brief. And the main thing is because I don't want you to tune out entirely, because Dr. Lori Robichaud is still to come. And I think it'll be really important to hear her talk, because I'm in Ontario and Ottawa, we haven't been hit by the COVID wave yet. And so there's so much learning opportunity to get from, I'm sure, Lori's experience in Montreal, where they are being hit harder and harder. And so please stay tuned. So really, I don't have too much to say, only because the evidence is out there that, the other speakers have already incorporated, that it is really, unfortunately, and realistically, a lower level of evidence. Case reports, letters, expert opinion. And really, we're extrapolating a lot of the existing evidence out there as it applies to COVID. So there's no doubt, in terms of the cardiac items that Dan had already highlighted, the evidence for it. And it's great to see the American Society of Echocardiography, ASE, say that POCUS is first line. It's unheard of, certainly, that an organization like that would suddenly say that POCUS is first line, and there's nothing like a pandemic to put emergency medicine in particular in the spotlight for this. But I would also argue that with that expert opinion, that we need to be cautious. And I'm cautious about it when the ASE has, for so long, we've had different disagreements, some collaborations. Should suddenly another organization should say that POCUS is first line, I have to catch myself a little bit and say, why are they so keen for us to do POCUS now? What's changed? And I think the reality is it's fear of the unknown, and actually the risk to ourselves as healthcare professionals and the team members. And so with that, I want to make sure that we understand what it is and why we're doing based on the evidence, and how social media is playing a huge role. I think one of the most gripping things that I learned from Twitter so far is following Dr. Yale Tung Chen's Twitter feed, his daily account of his own illness, seeing the lung ultrasound and the results and how he was feeling. For me, that was really inspiring and enlightening. Also to manage my own fears of what if I get COVID. And how that is. And so I thought that was a really powerful tool, and then my own passion for POCUS, how that incorporates. I noticed one of the questions earlier was, should we be using lung POCUS in all cases, and even the walking well patients, normal vitals and things? And I think that's a great question, because I don't actually know. Because as the example from Dr. Yeltong Chen's sort of thing, you could see the lung findings early on, but he felt great. And in a normal, healthy patient, if I were to do that, would that suddenly sway me doing something where I think, oh, maybe they should be admitted, maybe I should be giving antibiotics, and it becomes more confusing and confounding. And so it's important to recognize that level of evidence and then trying to apply it into your own setting. There are pitfalls with social media, and the pitfalls, and I'll relate it to how COVID is right now, is the example of in New England Journal of Medicine published the article, and I'm sure many of you read it, the artificial environment of droplets being sent everywhere. And suddenly I saw Twitter blow up in terms of these inventions and innovations of boxes for intubation to protect healthcare workers and the risk of acquiring those. I think it's amazing that happened so quickly, and it wouldn't have happened without social media. And it spawned a whole bunch of innovation and ideas. But we got to pull back a little bit and understand. And one of the other speakers had mentioned this, I can't remember who now, I think it was Dan or Joel or Chuck, and maybe all three of them. It's really, we got to take a second here, and it's great to innovate, great to generate ideas, but don't do this for the first time. You got to test it. And I have to give a shout out. Also, I've heard otherwise. The Human Factors Group out of Toronto, Dr. Petrosoniak, just demonstrated and analyzing the effect of the box. And is it really end all be all? And we don't really know in terms of what is really the risk. Certainly, we realize that aerialized generating medical procedures, or AGMPs, are higher risk for transmission and infecting us. But I'm not sure, based on the evidence out there, is the box is really going to do what we need to help us. On the other side of it, it's been really helpful, and I'll give you the example where the New York physician, Emerge ICU Dr. Cameron Calsadell on Twitter, I saw his feed, all of a sudden really provoking Twitter remarks saying, don't intubate these patients. It was incredible how originally our understanding was, okay, early intubation's the way to go. They're hypoxic. They'll do better by intubation. But all of a sudden, that one Twitter remark, and then Dr. Philip Rolla picked that up, and further discussions and realizing the experiences in New York sort of countered that and said, hey, maybe we aren't doing the right thing by intubating these things all early. So I want to bring it back to how ultrasound can also fall into those pitfalls without the necessary checks and balances and research involved. And a great example is how we use POCUS in the setting of CPR. We always felt that POCUS has no harm, no radiation, easy to do, repeatable. But Clattenburg's study on delays in CPR with POCUS being done. We were not doing CPR because we were doing the POCUS, and that is harmful in that setting. And so we had to take a step back and understand and refine that, what we're doing is not necessarily benign all the time. Another example, POCUS for DVT, making sure that we get the right protocols and different things. And where initially we were doing just 2 points looking for DVT, and suddenly, hey, wait a second, we look back and we were missing them. Our accuracy was not as good. And so that's important follow-up research so that we can refine our protocols and make us better. And so we need to look at this with some humility. And although, we are all passionate about lung ultrasound and cardiac ultrasound and POCUS in general, I think we have to, take a pause every now and then and reflect and see what we're doing. From the image generation point of view, a lot of debates, even as we're trying to develop protocols on lung ultrasound and different things, we have a lot of debates. What's so unique about COVID versus other lung ultrasound and other settings is probably, for me, the idea that they're more posterior lesions as described from Joel's talk, as well as the skip lesions areas. So that before we were, I would say, relatively cursory in our CHF patients or perhaps looking for pneumothorax, In these COVID patients, we actually have to be probably a lot more systematic and scan a lot more the whole lung in order that we don't miss those areas. Now, this is only my expert opinion, but I suspect if we do what we do normally, that we are likely decrease the diagnostic accuracy of that. Which leads me to the next thing in terms of diagnostic test characteristics. We don't have a lot of evidence for how it performs in the COVID patients. I think we have really good evidence for pneumonia. We have very good evidence for ARDS, and we're extrapolating again, but extrapolating is not necessarily the best evidence that we can go for. When we look at expert opinion again, Chest Journal has just published something from the Flexner Society. It's a group of thoracic radiologists recommending different imaging strategies in the setting of COVID. And in it, they specifically mentioned ultrasound and not to use it. And what they said was it cites limited experience and because of infection control issues. And so I find it interesting that you have, on the one hand, the ASE recommending POCUS be first line, and in Chest Journal, the thoracic radiologist recommending no ultrasound because of the lack of evidence and infection control issues. And so I think that's a healthy debate. It means the answer, the truth probably lies somewhere in the middle. The anesthesia critical care groups have all come out with guidelines indicating the need for POCUS and the role for POCUS. And I think from Dan's talk, I think it is a good idea to remember what we use POCUS already for the shock patients, alternate diagnoses. There's still very much a role for it. But the ongoing questions beside the diagnostic test characteristics is also the monitoring. So as brought up by Joel, can we use it for monitoring? Can we predict who will be intubated, who needs to be admitted? Those are really important questions and really patient-oriented outcomes. But we don't have enough evidence to say black or white. Yes, this patient, if they have lung ultrasound findings, they need to be admitted or intubated. Or no, they don't have lung findings, we don't need to do anything else or don't need to worry. I don't feel comfortable to say strongly one way or the other yet, but that's why we need to continue to look for that research and generate good research about that. The other thing mentioned was looking for lung recruitment strategies. So the idea of consolidation or in the lung ultrasound, is it predictive of more helpful proning being effective, or changing our vent strategies to help us? I think those are good questions to ask again. And then how does POCUS integrate into existing algorithms? So already we have DVT and PE algorithms, Wells criteria, different things like that. And we know from our case series from China and our colleagues in Italy as well, that they're hypercoagulable, these COVID patients. But we're using, again, falling back on old tests like the D-dimer. I read one study, if the D-dimer is greater than 1,000, recommending full anticoagulation. Well, surely there's got to be a role to further triage these patients with POCUS. If we have good POCUS scans demonstrating there's no DVT and there's no signs of right heart strain whatsoever, well, is the D-dimer that highly reflective of acute PE or large PE causing whatever clinical symptoms they have? So I think we need to look inserting the POCUS roles into some of these more established algorithms and trying to understand that. So what's going on with research now? There's big registries starting to perform. The Society of Critical Care Medicine has the virus registry, multiple sites in the US and other internationally. On clinicaltrials.gov, there's a couple studies that I saw just looking at some test characteristics. Dr. Gabby Bletcher in Monash in Australia, in Melbourne, is trying to do a lung ultrasound diagnostic test character studies involving partners, myself in Ottawa and others in Montreal, as well as Ireland and US. And so what I also find really great, and Chuck really highlighted this, is the beauty of social media and Twitter is being able to connect with people all over the world, and not just in exchanging information and new ideas, but generating more research and ideas and consolidating and challenging each other to a certain extent, questioning what we do and to find what the truth is. So in the end, what I wanted knowing that every context is so important, where the research is done, where the expert work is, what do they come from. Critical care is not entirely the same as a walking wounded type of center in emergency medicine. Emergency medicine in Italy, I don't suspect is the same as emergency medicine in Canada. And so it's trying to understand those work environments as you interpret these expert opinions as we go forward. So I'll leave with the following questions, which is, you have to ask yourself, what kind of user am I right now? And if you're a novice user, is this really the time to be learning an extensive lung ultrasound protocol, recognizing that the more time you spend in the room next to that patient, are you potentially exposing yourself needlessly for potentially not necessarily diagnostic information? So I'm not saying it's wrong, I'm not saying it's right, but you just have to ask yourself that question. The other thing is, what kind of local resources do you have? So if you're in an environment that you actually have to call in the X-ray technologist, I worked up in Barry's Bay, a small hospital, St. Francis Memorial Hospital, a couple hours from Ottawa, where after hours I have to call in the X-ray technologist and potentially expose that person to some concerns for COVID, other resources, limited areas. And then maybe that's a better center to use focus given that current environment. And it's already been highlighted, the role of X-ray and the potential issues with CT. Working at my academic center, if I send a patient for CT who has suspected COVID, the time to clean it is a big factor, and it affects the care that you provide to other patients. That stroke code patient that comes in next, that trauma patient that comes in next, and if they're spending 15, 20 minutes cleaning the CT, that has potential impacts on other people where POCUS may play a role to temporize or triage things accordingly. And then the most important question is, will it make a difference to your decision making? And that, I think, is the biggest question that you have to ask yourself. And understanding it, then by all means, go ahead and do it. But if it's not really going to change anything to your decision making, I don't think the benefits or the risk to yourself or to others and the necessary cleaning that is required is the right way to go. And I think we need to do more research. And I really encourage you, it's fun to share the information, our anecdotes, and we learn tons from that. But I encourage you to reach out to the different researchers, provide that data so we can get social media to critically appraise that better, higher level research and improve our practice of POCUS accordingly. Thanks very much. I'm happy to entertain questions. And that's my rant. I have to excuse if there are any of my fellows or residents get to hear me weekly at our rounds rant like this, but I appreciate your time, and please stay tuned for Dr. Robichaud's talk, because I think she'll really tie everything together here.
Thank you so much. So far all of the questions have been answered for the most part, but and you reflected on this in your talk, Mike, but just for suspected COVID positive patients with normal vitals, would you even bother doing a lung ultrasound then?
Yeah, I struggle with this, and so I haven't seen a lot of them yet. And so, I think it depends on the patient. So right now, if I have a patient who is really, really low risk, I'm not even doing an X-ray. And to be honest, I've checked my stethoscope as well. I don't even bother listening to their chest anymore. And the caveat, okay, this is only my expert opinion. I don't have any evidence for what I do. In the slightly higher than low risk pretest probability patient for COVID, I think I might use it if I think I might be able to help them recognize the seriousness of the need for self-isolation. If the understanding of looking at an abnormal lung ultrasound is going to help them, regardless, I've already made my decision to discharge them based on their vitals and their characteristics at home, other patient factors. So for me, I always make a decision prior to doing my ultrasound if I'm going to do it in those low risk situations. In the high-risk situations, I think there's still definitely a role because of we're looking for all those other things. We're looking for well-established things for POCUS already, looking at the heart, looking at the veins, putting in central lines, all that type of stuff. And so for that, I would, in the high pretest probability cases, and potentially decrease the need for CT, although that's controversial, I recognize that. And so it's the really that intermediate category is, as always, the hardest one. And as always, it has to be interpreted in the clinical context.
Thank you. That's excellent. So without delay, we'll hand it over to Dr. Rovi Cho, who is also in Montreal. And she's our last speaker for this evening. Thank you.
Hello, can you hear me? Okay, let me just, is my screen shared now? Very good. So thank you so much, and I feel like an imposter following all these great ultrasound guys, but I'll try to put it all together for all the good things that have been said about this hot topic of ultrasound and COVID. So I do not have any conflict of interest to declare for the presentation, and let's just go over the two things I want to talk about very briefly, but are quite important. I want to discuss my overall thoughts about my POCUS experience, or the POCUS experience we've had from Montreal, especially the Jewish General Hospital, in this context of the COVID pandemic. And I also want to give you guys, because I know you're working in very various ED centers, so some academic, but also some smaller centers. I want to give you some practical tips onto how you can integrate POCUS in this COVID pandemic. So let's go. So this is actually a beautiful picture of Montreal. In a very nice spring afternoon, vibrant, very busy, a little bit chaotic, very similar to my emergency department, which is a Jewish General Hospital. And this is it now, right? Montreal in the pandemic area, naked, ghost city, very similar again to my emergency department, with the exception that there is COVID everywhere. And to illustrate this, here's a graph. Thanks to Bernie Unger for that beautiful stats and graph. You can see that at the beginning of basically mid-March, we were seeing close to 300 visits per day. So very high, busy emergency department. And then all of a sudden, we got hit. We got hit by the pandemic. And then all of a sudden, our numbers drastically decreased. And then we became what I would call a COVID ED. In this COVID pandemic, all of a sudden, I got scared. We all got scared, right? With all this PPE, all this new procedure, needing to have patients in isolation room in these hot and medium and warm and cold zone, it became a bit complex. And to be very honest, at one point, I just stopped doing ultrasound. I was very afraid that, honestly, I would contaminate the whole emergency department if I would bring my machine. I was wondering if it was actually safe to use POCUS. I'm wondering if there was any role for it, and specifically in the COVID patient, like, am I going to be able to diagnose them just with POCUS? And then do I really need to take the risk and bring my ultrasound machine in the room? I also felt that it took me a lot of time to prepare to get, done for these patients. So then I was like, maybe it's not worth it just to bring the ultrasound machine and done it also. So I was really wondering, was it really worth it to do POCUS for these patients? And then we start seeing cases. So again, another nice graph, basically doing a little summary of what we've seen so far. So at the Jewish General Hospital, our experience is that we've seen close to 2,000 rule-out COVID visits. I would say that about half of them, or a little bit less than that, are truly positive COVID. The other ones were just rule-out, yet you still done like it's a COVID patient. And then that means approximately 60 rule-out COVID visits per day. So that's a big number of patients. The problem became when I was, I've been ultrasounding almost every patient for all my shifts, and I've become extremely comfortable or uncomfortable not having my ultrasound to do the assessments of the vast majority of my patients. So now all of a sudden, I was seeing a big number of those COVID patients, but sometimes the diagnosis was quite unclear, right? They could have some chest pain. They did have some CHF prior to presentation, and now they might have a small fever. Was that a CHF exacerbation? Was that COVID? I was very uncomfortable. And then I realized after all the experience that we've got and all the patients that I've seen, that it's absolutely worth it. And I'm sure that the other presenters were able to convince you that actually POCUS is worth it in COVID. But let me give you a little bit more of my practical tip to integrate it in your practice. Because, I'm sure you know that ultrasound is a fantastic tool, and we've all been integrated in our daily practice. In all emergency department, there is now an ultrasound machine, I'm sure, and sometimes more than that. But then how to integrate it in the COVID pandemic is another question. And here's some of my practical tips that I've developed in the last month. My first tip for everyone is basically just be ready. Be ready to do your ultrasound. The first thing to do is actually make sure that you have a local protection and disinfection protocol. You can either do it yourself, just like we did at the Jewish General right at the beginning of this pandemic, or you can just adapt it from a really good one. And again, I don't have any tie with CPOCUS except that I'm a CPOCUS instructor at this time. But their protection and disinfection protocol is fantastic. It can be printed in a small PDF sheet. You can keep it in your phone as a reminder before you go into a room. And it's also translated in 1 million languages. So it's a fantastic tool to have. Talking about that tool, that's exactly what we did at the Jewish General Hospital. So we got these protection protocol of the protection disinfection sheets plastified, and then we put them on our ultrasound machine. So whenever you're doffing your machine or you're donning it, you can remember what to bring. It's readily available to remove that cognitive load of having to deal with an extra piece of material that you need to keep clean and avoid contaminating yourself. Other thing to be ready, if you have the luxury to do so in your emergency department because you have multiple systems, well, try to have a dedicated COVID ultrasound machine ready to go, donned in a specific part of your emergency department. So when you decide to don to go see a COVID patient, you just grab it and you're ready to go. My next little pearl is to think small. And why am I saying this? It's because I've realized that these big machines, they can be kind of hard to manipulate in the room where sometimes it's a little bit crowded, but it's also difficult. First resuscitation I've had, I honestly contaminated the whole machine because I realized at one point that I wanted to use the other probe and I didn't prepare it before, and then I had to touch the machine. Getting out of the room after the leading this resuscitation case, I'd spent 30 minutes disinfecting my machine, which was definitely not appropriate. So now I just bought myself a little butterfly ultrasound probe. So handheld ultrasound are actually an excellent tool to have in your toolbox if you're able to afford it. What are the advantages? Dan actually spoke about this a little bit, but they're really easy to don and to clean. Sorry. It's also very good because there is a cloud and there's connectivity, so you can store your clips just like you do for your usual documentation in your emergency department. It's also, I would say, a good image quality. I will admit that it's definitely not as good as my big ultrasound machines that we have currently at the Jewish department or at Hôpital du Surroi where I also work, but it's still adequate to answer the questions that I have for those COVID patients. Also, little trick that I've really learned quite quickly, try to get an old phone. You definitely do not want to have your personal phone go into a COVID room and then, I don't know, calling your family member right away and right after your shift and then having the potential of having a tiny bit of that COVID virus on your phone. Definitely not something I would recommend. Just try to buy or get one of the old phone to use with your NL device for those who actually connect, of course, because there's multiple other devices that you can find. I think everyone mentioned this tonight. Use it wisely. This is a tool that can potentially contaminate yourself or contaminate other people around you if you don't clean it properly. Make sure that you follow some of the general principle. So try to only use it when you have a specific indication to use it. So if my patient is hypotensive, I have a few answers. I want to know, do I need to give him fluid? How's his heart function? How's his RV function, right? Am I dealing with a venous thromboil, a PE? Or am I dealing with a severely dehydrated patient? Because we know these patients have diarrhea. And from most of the hypotensive patients I've seen, they were actually quite hypovolemic in the context of dehydration and poor PO intake. So make sure you go in with your POCUS with a specific question to answer. Also, make sure that it's not the time for you to go and teach at bedside. So at the JGH, where we're a POCUS center, we basically stopped all elective and fellowship teaching. Try to make sure that you're giving the ultrasound probes to people who actually will be able to obtain those answers. And that's it. So make sure that you use it wisely. At the same time, you have to use it. I was telling you at the beginning of the pandemic, I was doubting its use. Well, as I was telling you, I was really feeling that I was a suboptimal doctor without my ultrasound machine for those hypotensive cases, for those post-intubation COVID patients that all of a sudden were desaturating. Did I cause a pneumothorax? Did I do a right mainstem intubation? I needed to have some answer quickly at the bedside, while the portable X-ray I know is going to take minutes and minutes, and I need to act quickly. So we know all the benefits of POCUS. I don't need to tell you. I'm sure you guys are using it on a regular basis. I think if I can do a little summary, it's just to use it, but use it wisely in a safe way, and try to take all these little practical tips that I gave you to really try to integrate it in your ED so you can use it efficiently. I'd like to thank actually all my colleagues, all of you guys who are doing a great job. This is my ED family at JGH, and I thank you very much for your attention.
That was great, Lori. Thank you so much. Just a question for you. Have you heard of any people having issues with their institutions about privacy related to uploading ultrasound images to the Butterfly cloud?
This is an excellent question, and actually, I wanted to discuss with the rep of the Butterfly specifically. I know that it's actually protected from your phone. You cannot store any images on the Butterfly probe if you don't have a code on your iPhone. It's also stored in the cloud. In theory, that's supposed to be secured, but that's something that I've actually wanted to look into a little bit further. So far, what I've done is I've just saved the time and the date with just some initial, nothing to identify patients. But this is something we'll have to start thinking about. Very honestly, I got my Butterfly this week, so I've been starting to use it only this week. We've ordered a few of those devices for the emergency department, and I know many of my colleagues, Sur-Roi, Saint-Jean-sur-Richelieu, and everywhere in Canada, basically ordered some of these units, and it's going to be something that we actually could go come back to you and tell you about once I have a definite answer.
That would be helpful. Perhaps on the forum, we can direct questions, additional questions or answers to that, and that would be helpful. So I'd just like to thank everybody tonight for their time. I found it was a very informative and fascinating session, and I hope that, well, I'm sure it'll actually change my practice, and I will continue to use ultrasound in my practice at McGill. So thank you, everybody, and thank you all of you out there who have attended our town hall this week, and we'll look forward to seeing you again next week. So for now, bye-bye, stay safe, and have a great rest of your week.